Hey, hi guys, Dr. Dan Nightingale here, your clinical dementia specialist. I hope you're having a fantastic day, a fantastic week, wherever you may be in the world. Thank you for joining me on today's video, where I'm going to kind of discuss and take you through a walk through dementia. So, dementia, there are over 100 types of dementia type illnesses, so subtypes of dementia. We prefer to refer to it as a neurocognitive disease or neurocognitive decline because it helps us identify and kind of break down exactly what type of dementia a person is living with. The most common type of dementia, so around about 80% of all dementias, are Alzheimer's disease. Alzheimer's disease does not just affect older people. The majority of people with Alzheimer's disease are over the age of 65. However, young onset Alzheimer's disease impacts on people under the age of 65. So people of working age, and they can be any age, 20s, 30s, 40s, 50s. And it impacts people differently than older people who have Alzheimer's disease. Why? It's mainly around about lifestyle, socioeconomics, and the political picture, the social history and those kind of things. People with young onset Alzheimer's disease may still have a family, a growing family. They may have kids in college, in university, so we're funding that. They may have a job, car loan, car payments, mortgages, many financial commitments that they're still responsible for. Plus, the impact that having Alzheimer's disease on a younger person from a psychological point of view is different as well, and I'll talk a little bit more about that later. Older people, i.e. over the age of 65, who have Alzheimer's disease, have a little bit of a different way of dealing with it because they may not have all these financial commitments any longer. They may be stable, more financially stable. I mean, that's the idea, that's the dream, that's what we aim for. So they may have retired from work and they may be enjoying life in a different way to what younger people do. So Alzheimer's disease starts with three key features. The three things that I look for in somebody who may have Alzheimer's disease are disorientation in time and place. So not sure what day it is today, not sure how to get from one place to another, not sure what time it is. If you ask the majority of people, what time do you think it is, without looking at a watch, they pretty much get it more or less right. If you ask somebody with Alzheimer's, they might not be able to do that. So I'm looking at disorientation in time and place. I'm looking at issues with immediate memory, working memory, short-term memory. Okay, so I can remember what I had or what I did 5 years ago, but did I have my breakfast yet? And thirdly, I'm looking for people who can't follow a sequence of events, a straightforward sequence of events that they've done all their life, like tie their shoelaces, things like that, bake a cake, make an apple pie, so apple crumble, what do you call it in America?
Pie. Cobbler.
Cobbler, an apple cobbler. So, they may end up putting salt in there rather than sugar. So there's those are the three key things that say to me, there is something that needs further exploration. These are what we call the early stages of the disease. So those things would be early. They would be the early onset as opposed to young onset. Okay, so somebody who is 23 who has young onset will also have the early stages of the disease too. So I think Lynn wanted me to clarify that, to make the distinction between early and young, okay? So Alzheimer's disease, and then the picture of Alzheimer's disease as it unfolds. So if you walk through that journey, those are the first 3 challenges that we face. And then obviously we go and get an evaluation, get the right treatment and therapy. What is the right treatment and therapy for early onset Alzheimer's? Well, very often it's a cognitive enhancing drug such as donepezil, Aricept. That's usually somewhere that you go to first and foremost. It doesn't work for everyone, and there are a couple of other drugs that might be replaced, that might replace Aricept, donepezil, if that doesn't work for that individual. And that would be a medication called galantamine or one called rivastigmine. Those are what you look to help slow down the progression of the disease. In addition to that, currently we have some monoclonal antibodies, which is an infusion medicine for very early stage Alzheimer's, which clears up the neuritic plaques in the brain. So Alzheimer's disease is typically caused by a buildup of beta amyloid plaque in the brain. What that does, it sticks to the brain cell, clumps it all together, and kills the cell. So what we're trying to do with the monoclonal antibody infusion is clear up the plaque. So that is a new medicine, and that is available in the US for people, only available in the UK through research. So they're still not happy or still not certain about it yet to fund it in the UK, whereas it is fundable here by the insurance companies here, being the US. So those are the medicines that people would be using. As the disease progresses, so remember, these medicines now are to slow the progression. There is still no cure. We have no cure for Alzheimer's right now. So the disease will progress, but it takes much more time if we're being treated effectively. So what does happen over time? We start to have mobility and balance issues. We might have visual disturbances. The recognition aspect of recognizing friends, recognizing people, trying to remember their names, who they are, what relation they are, may become more of a problem, more of a challenge. People might have difficulties with instrumental activities of daily living, such as making eggs. Been doing that forever, but now it's too confusing, they can't do that. Or activities of daily living, which is eating the eggs independently once I've made them. So you've got instrumental activities of daily living, and activities of daily living will decrease and minimize over time. And when I say over time, this is where it's individual. So it could be rapid or it could be very, very, very slow. If you're having the right treatment and the right therapy and the right support, it's going to be a lot slower, the progression of the disease. Because along with the medicine, we want to use other forms of non-pharmacological therapy, such as cognitive behavior therapy, brain health therapy, and also hypnopsychotherapy. Very, very good, proven modes of therapy to help people deal with situations, manage anxiety, manage fear, because the two fuels that are involved in rapidly moving forward the disease progress are anxiety and fear. And if we can manage those two things, that is a massive help in slowing down progression of the disease, along with the medicine that we might be taking too. Mobility issues, IADLs, ADLs, speech and language, not eating properly, the body starts to shut down. There's various parts of the brain that get impacted and damaged that impact on sleep, affecting your sleep. So weight loss becomes an issue. And eventually the whole bodily system closes down. And then that leads to end of life. But let me just point out here that very rarely is any type of dementia the primary cause of death. It's usually something totally different, like pneumonia or a heart or a stroke, heart disease, heart attack, cardiac arrest, that kind of stuff. So that's Alzheimer's disease, and as I said, it impacts differently on different people, depends on your age, depends on your comorbidities. So do you already have other illnesses, diseases, disabilities? And it's very unusual to have just one type of dementia. So we've just spoken about Alzheimer's disease there. Vascular dementia is the second most common type of dementia that we see. Vascular dementia, the picture is similar in the way of if you walk through dementia like we did with Alzheimer's disease, you're not doing much different. The symptoms, the progress, the impact is very similar. But rather than it being caused by some over build-up of amyloid plaque, it's to do with mini strokes, TIAs, transient ischemic attacks, that lead to dementia-type symptoms similar to Alzheimer's disease. We have in the brain something called a cerebral reserve, and it's a bit like a car. In your car, you have a red area for the fuel, which is telling you you're running out of fuel, and the emergency fuel for the next 50 miles or so kicks in. Okay, we have something similar in the brain called a cerebral reserve, and that will kick in and rewire some of the damage that has been done by a tiny stroke, by a TIA. But that gets used up, and unlike a vehicle, we can fill that up and it's back again. This is gone now, there is no more left. Research shows us that the higher educated the person, the more reserve they have. So that's a thing that was found in research. So we have that to help. Once that's used up, if we go and have another TIA, then we're going to start seeing the symptoms present. And very often you'll see Alzheimer's disease and vascular dementia working side by side together. And sometimes, and the Nun study, Aging with Grace, taught us through brain pathology that sometimes you can have those neuritic plaques and tangles in the brain that is symptomatic of Alzheimer's disease that never present with the disease unless you have a stroke, and that tends to trigger it. So that's an interesting piece of information and research. The third type of dementia is Lewy body type dementia. Now, Lewy body type dementia is a little bit different because it impacts people in different ways, and it sometimes presents like Parkinson's. There's very much of an overlay between the two and a relationship between the two. So the part of the brain that is impacted by Parkinson's disease is also impacted by something called a Lewy body, which is a protein in the brain, in part of the brain called the substantia nigra, that causes the Lewy body dementia. And what we see there as we walk through that, we see the personality changing first and foremost, as opposed to the memory. Behavioural issues, challenges with behaviour that we don't often see until the person gets Lewy body dementia. Hallucinations. Now, whilst hallucinations can affect anybody living with a neurocognitive disorder, the people with Lewy body dementia impacts on them pretty hard, and they are pretty severe hallucinations. You could be seeing monsters, you could be seeing things crawling on the walls, snakes crawling on the carpet, insects, things like that. So that is obviously impactful on the person. So what can we do about that? So I'll talk to you about the treatments for Lewy body in a moment. The other thing with Lewy body dementia is falls, the balance, visuospatial difficulty. So if I have a grey carpet on a grey floor, if I've got wooden a floor that's grey and my carpet's grey, I might struggle to see where the carpet finishes or the rug finishes and the floor begins. I'll struggle to see where the wall ends and where the floor begins if the colours don't contrast. Okay, so those are the things you look out for Lewy body, and that might be an indicator that it is something other than Alzheimer's disease. So then we get evaluated and get checked for that, and what is the treatment for that? How do we work through that? We're trying to manage behavioural issues and we're trying to manage hallucinations. The type of drugs used for that commonly are called antipsychotic medicines, neuroleptics, and we can't use them safely with people who have Lewy body dementia. The medication, people with Lewy body dementia are very, very sensitive to those medicines, and there's a risk of doing some real danger and damage to that person, including death. So it has to be evaluated, it has to be managed effectively and closely. And if we do need to use medication, the smallest medicine dose possible for the shortest time possible. Okay. So the other way to manage hallucinations, of course, is to step into the world of the individual, acknowledge that these things are here, and then redirect. So, yes, John, I can see what you're talking, I see what you mean. I think maybe if we leave the room, go out and maybe sit outside for a little while, or go for a walk, or go and do something, watch a movie or have a conversation. When we come back, they will have gone away. So we're trying to manage that, we're trying to validate the individual's experience, and we're trying to manage it, and then we're trying to alleviate those symptoms. So it might be a combination of medication, small dose, with non-pharmacological engagement and interaction. Okay, so that's how Lewy body. And as that disease progresses, it tends to be a disease that affects older people and progresses a little bit quicker than what Alzheimer's disease would. I spoke earlier about Aricept and donepezil, Aricept. It can be very effective for people with Lewy body dementia too. So it might be something that's used for that as well. Okay. And then I want to talk just a little bit about frontotemporal lobe dementia. I'm beginning to see more patients presenting with frontotemporal lobe dementia of the behavioural variant. So we can have frontal lobe dementia, it affects your behaviour, your personality, wipes out your inhibitions. And that is why we end up with the behavioural form. Once those inhibitions have been wiped out, there is nothing to hold people back. There is nothing in place for inhibited behaviour. So we might see people who are now using foul language. They might become verbally aggressive, they might become physically aggressive. And so we need to be aware of that, and how does that work. That's very, very challenging for everybody concerned on that journey. There's going to have to be a multidisciplinary approach to supporting that person with the behavioural variant. So very complicated and very complex, but again, it's about meeting their needs, it's about validating their belief systems. It's not about confrontation, arguing, fighting, or anything like that. It's about validation, acknowledging, embracing, and then using both pharmacological and non-pharmacological approaches to help that person through that journey. And in all of these dementias, they're all called primary dementias, which means they are the main types of dementia that cannot be cured. Okay, so in all of those dementias, it is a journey involving a village to support the person, and the family also needs support. So everybody needs support. And the people who watch my videos regularly know that I look at it from the point of a movie. The person living with the dementia is the hero of the film, of the movie. And the rest of us, family, friends, professionals, caregivers, we are all supporting cast to make sure that that movie is as enjoyable as possible. So it's about quality of life here, making sure quality of life is as good as we can possibly make it. Let me just throw in a couple of things about non-primary dementias. And one of the most common ones that I see and work with is normal pressure hydrocephalus. Okay? That is where there's too much fluid, cerebrospinal fluid, built up, and it causes people to have balance issues, confusion, agitation, frustration. And so what has to happen there, this can be cured. This is the thing with a non-primary dementia. We can treat, we can manage, we can pretty much cure it with a shunt. A shunt is fitted into the brain, the lead goes down into the abdomen, and the fluid is drained off into the digestive system, and it's used, the waste products, just like everything else, we get rid of it. So I would just want to throw that out there, because that is a form of dementia that is manageable and curable. So a walk through dementia, just let me summarise that, because I know this has been a lengthy video, so it's time to wrap it up. But to summarise it, it's individual, it impacts on any age group, but the older you are, the more likely it is that you might get it, but not necessarily, don't have to get it. There are preventative ways of reducing your risk of developing it. So I want you to think about your lifestyle. I want you to think about brain health, therapy, which we all have to do every single day, whether we do a crossword puzzle, whether we draw, colour something in, whether we use our non-dominant hand, follow my rule of 7, whether we use a, get this here, Springbok jigsaw puzzle. You know, I like Springbok jigsaw puzzles, and I'll tell you why. They are bigger pieces, easier to manipulate, the colours are appropriate, and they're pretty challenging, but they are absolutely the most appropriate thing that I have ever found for people who are living with dementia. So jigsaw puzzles, doing jigsaw puzzles on a regular basis also is good for your brain health. So I want you to remember that it might not be inevitable. So no matter how old you are, no matter how long you live, it might not be inevitable. You might be able to manage it through brain health, especially through brain health, managing your stress and anxiety in life. Okay, and don't worry, because worry is something that is in the future, and the future's not here. Focus on the present moment. Enjoy every second, every moment of your life. I know Lynn wants me to wrap this up, but I'm not finished yet. So I just want you to know and understand that dementia is not a death sentence. As soon as you get a diagnosis, do something about it. You're in control. Do something about it. Work closely with your neurologist. Work closely with your clinical dementia specialist. Work closely with whoever it is that can help you and support you. Don't turn away any support. Don't think, oh, it's okay for now, I'm going to be all right. There's no time to waste when you get a diagnosis of Alzheimer's disease or other form of dementia. And as I was saying, there are children. 1 in 150,000 children are also born with a dementia, and it presents around about the age of 10. So it can affect anyone. Look after yourselves, look after your physical health, look after your mental health, look after your brain, give it a workout regularly, and your walk through dementia is going to be a lot more pleasant. Thanks for listening. I appreciate it. Remember to share the videos. Remember to follow me on Instagram and Facebook. Get people to subscribe to the YouTube channel. And remember, say it with me. Dump the soda.